Hi guys, Don here. Thank you for joining this masterclass on custom AFOs. So what we're going to go over today is how to determine what patients would benefit from custom AFO. So I want to just give you guys a little backstory. This was a lecture that I gave for the AAPPM, and I'm always a big advocate. If you're going to do something once, you want to turn it into something that's evergreen. So for example, in our office, we do a lot of webinars. And then after we do the webinar, we will put it on YouTube. So it's evergreen. We'll send it out to our patients afterwards if they have information. I'll put it on like a membership site. So whenever you're doing something, you want to not just do it once, you want to use it over and over and over again. And so I'm going to go through, but in a little bit more detail than I did with this other lecture, because I want to show you all the tips and tools that I use that I find helpful. Okay. So the whole goal when you come away from this is you're going to have a better understanding of when to use custom AFOs and how to use more of them. I'll explain some things that are working in the office for you. Once again, if you guys have any questions, put them underneath here in the comment section, and I'll try to get to them probably at another time, maybe at the next webinar. Okay, and all the resources that I'm going to refer to, I'm going to put underneath here in the comment section or in the description here. So let's get into it. What's the problem? I think the whole problem is that we don't do more because we don't offer more. So we don't do more AFOs because we don't offer more. We don't do more shockwave because we don't offer it more. We don't do more orthotics because we don't offer it more. I think the whole problem is we're not doing it more either because we're way too busy. We're going from patient to patient, and there's no really easy way to explain stuff. But we're really not offering it. Now, the offer could be because we're not confident or because we're just too busy. So the way to get away from being busy, I think, is using the presentations that I've talked about before. That's what helps me to slow down. And I use videos to kind of reinforce things. And I use these checklists, and I'll talk about those as we go on. But I think another reason, if you're learning something new, is we're not offering it because we lack confidence. And you might think, oh, but I'm a confident doctor, or I'm confident in myself. What I'm talking about confidence, this is a topic I've learned from Dan Sullivan. So he's the guy that I get coached with. It's the 4 C's. Okay, so let me just review this quickly. I'm not going to teach it. He's got tons of resources on it, but I want to highlight it specific to podiatry and specific to durable medical equipment and specifically to AFOs. So you have to have commitment. Okay, so commitment means you're watching this on AFOs. You really want to do more AFOs because you see the benefit for your patients. You see the benefit for your practice and things like that. So you're committed. Okay, you're watching this. Now, after you watch this and you've committed to watching like for the next 30 minutes or so on this, then it's going to take courage, okay, to actually do it. Maybe you don't have any DME AFOs in your office and you need to find a vendor. Maybe you need to get a couple of samples to see what they're like. Maybe you need to figure out how to teach your staff how to cast for them or scan for them with a 3D scanner. And once you kind of do that, that's going to take courage. You're going to have to learn how to bill for it. There's like a lot of things you have to do, and that takes courage. It takes work, basically work. Then you're going to have to develop capabilities. These are some of those capabilities that I talked about. So some of the capabilities are like the billing capability, the scanning capability, the figuring out who it works for capability. And then only after that, okay, and after you make mistakes, you're going to get confidence. Okay, the confidence comes from taking action when you're not courageous and when you don't have any capabilities, so you can go forward. Now, this is something I never learned on my own. You kind of equate it when you were learning surgery, though. It was very similar. Like surgery, we were committed to learn, and initially we didn't know how to suture. We had to have courage to do that. So we have some doctors that taught us, developed our capability, then we developed confidence. This is nothing different. The more you do it, the more you do AFOs, the more confidence you're going to have. Okay. So the backstory for me with AFOs is I pretty much did AFOs when I started, and I was offering them to patients. I didn't really have a good way of offering them, and I didn't really have a good system of offering them, and I wasn't doing as many of them. And then I started to have some difficulties with them, and you almost want to give up, right? And I did give up some things. I want to be very clear. When I started, I tried to do some wound care stuff, which I'm getting back into now. but I was doing like an alginate and a collagen, and they were sitting on the shelves, and either I wasn't offering them or I wasn't getting reimbursed or something like that. So I kind of lost my confidence in it, and that's why I stopped it. And I think there's a lot of things we'll start and then we'll stop because we don't have the confidence. So we'll start. Now, the good thing about AFOs, you can do one of them and you get reimbursed and you're fine. You don't have to keep something on your shelf, unlike other types of things like wound care supplies. So what are some of my pearls to begin? Well, I'll give you some of these pearls that help me out when I'm doing AFOs. First of all, the proper diagnosis, which we all should be able to do. I find what really helps me are doing like diagnostic injections, for example, into joints or to different areas to see if that's specifically the area. Doing ultrasound, I really find ultrasound, for example, of the posterior tibial tendon, things like this. This can really help you to explain that there might be a partial thickness tear, and then doing an AFO would be a good option for a patient with a flat foot and posterior tibial tendon dysfunction or shockwave or anything else. I really like to use case studies and videos to explain things. A lot of times I'll have someone come in and I'll introduce a topic, and I can even share a similar case. I had a similar patient like you that had this problem, and this is what we did for them. Or I had a similar patient, or and I learned this from someone else. If you were my mom or if you were my dad, I would do this, kind of explaining why you would put them into this AFO. And just that's a great expression. So if you have someone, an older man or older woman, if you're my mom, if you're my dad, and you really believe you would put them in an AFO, say that. Okay, so it's going to build credibility, doing different case studies of other patients that you've had. And I've explained a little bit in the past, but I use a case study basically when someone has a really good result. I'll go back and in their last visit, I'll say, okay, how was it before you saw me? And I'll write that down. How was it after you saw me? And what did we do? We did like shockwave, we did an AFO, maybe we did surgery, and I'll make that into a little video. So I'll take those case studies, put them into a video. You don't even have to put it in a video though, just documenting those case studies. This builds credibility. And if you really want to go to the next level, what you can do is you could have a patient record a video about that. They could share their experience. And then when you're talking about posterior tibial tendon dysfunction, you could have this video of this patient. That's kind of a great tip if you're willing to do the work for that. I like checklists. That's really just my easy way of doing it in these presentations. These are my protocols, and I'll show you these as we go on. Now, I would say pick one and start. Okay, pick one. Don't do 10 braces to start out with. Pick one that you see a lot of, and I'll explain what are the ones that I see a lot of, and you probably see a lot of if you have a similar practice. Just pick one and start with that one. Okay, as I'm thinking about going back into doing wound care in the office, dispensing things, I'm going to pick one. Maybe I'll pick the collagen, and I'll just do that. I'll get like 5 boxes and start dispensing them to patients. So I'm in the same situation with wound care supplies, because I don't do a ton of that in the office. I see wounds, but I don't do the supplies and things like that. So you have to pick one and then start. That'll help build your confidence. Once you see that it'll get reimbursed, right? That you're getting reimbursed for it. You're gonna build your confidence. Training staff, I think, is important to help simplify the process. So our staff, I try to get my staff involved. They do the STS casting. We don't use the scanner. We still use the STS. But then simplifying the process, having them come back, all the documentation that you guys need. I will put, in terms of documentation, you're going to need to know certain verbiage that you're going to be putting in, okay, as well. If you go to the 30-day practice blueprint that's on Podiatry Practice Mastery, in that 30-day practice blueprint under the DME section, I do have all of the written, like same and similar things, like everything's written out there for you. And then also knowing what to refer out. So I don't do everything in-house. I do have a local orthotics and prosthetics lab. We use Hanger around here because, for example, in my area, Blue Cross Blue Shield, there's a carve out that only Hanger can do their braces. So I have to send out the braces to them. But like Medicare and things like that, I can do the braces. So I have a good relationship with them, and I know what type of braces that they can do. So what are some of the common questions? When does a patient need a custom AFO? I don't think it's the first visit that you're seeing them. I usually try other things first, like I said. But then if those other things don't work, that's where I pull up my checklist and I say, hey, let's try this AFO. people have questions about how to make them work in shoes, and I'll explain some types of shoes. And are they worth it? I think definitely if you look at the finances of AFOs, they are worth it. What you pay for them and what they reimburse are good. I think as I'm learning now, I think even wound stuff is better because it's almost like an AFO every month, if you, depending what type of wound supplies. But this is a really good way to help patients as well, and you're not sending it out. Okay. So what shoes can they wear? I usually use a shoe that's about a half to one size larger. It has to have a removable sock liner, and I actually use this picture in my presentation to show them. And you'd like something that's extra depth. And there's a couple of places I send them to. Once again, I don't receive anything from this, but I just find it's easy. I have them go to either Dr. Comfort or one of these SAS shoe stores or something else like that, because it's not going to work in their normal shoes most of the time. They're going to need a special shoe. I don't do diabetic shoes in my office, so I'll send them out, and there's not many people doing them, so I'm considering getting back into it. But for me, the juice just wasn't worth the squeeze in terms of my staff. And what I mean by that, my staff didn't like doing them, and so you have to almost have an advocate or someone that takes it under their wing to do it. So what shoes? Here's an example of a shoe. This is a funny story. See all this moleskin right here? Well, this guy, he took his liner out, put his AFO in there, and it stuck to the glue that was on the bottom of his shoe, and he couldn't get the darn thing out, so I helped him. But you can see here, the laces, this guy comes out, but it really lifts up the tongue here. He can get his shoe, his AFO inside of there, and this is inside the brace. Now, one kind of cool thing that we have in our office is we have shoe horns. We bought a whole bunch of them. So I'll give patients when they're getting an AFO, I'm the one that dispenses them. I have a special dispensing note that I do, and I'll give them a shoe horn with it as well. So this is just an example of a patient. There are problems with AFOs. I want to be very clear. Some patients really just hate them. And since it's custom made, you can't refund them. You have to be very clear about that. But this patient had a gauntlet type of AFO right here, and he had some rubbing. He had really bad skin on the anterior part of his leg, and it did develop into an ulcer. So I guess I could have made more on the wound care supplies. I didn't do that, but you could do wound care supplies for this. But this gentleman, you can see this collapsing foot, and he did have a fracture of the metatarsal. This was actually, I did it because of this fracture, and I was trying to help heal this and just help his foot that was really, really crooked. And this guy does not have a foot on the other side. So this is something just to help stabilize him, but it caused this wound. So we have to heal this wound up, add more padding in the front, and then keep treating him. So for ankle foot orthotics, what I want to talk about, I put on this side of the page. These are what I typically use it for. There's a topic I talk about in the practice, the 30-day practice blueprint of the 80-20 principle. And that just means that 80% of the time I'm using these diagnoses, and 20% of the time I'm using these diagnoses. So I'm going to spend more time because I'm more confident, and I do it more, maybe because I have more patients with these conditions, than I do find it necessary to use them for these conditions. So I'll go into them, but I do use it for posterior tibial tendonitis. This is the most common one that I use it for. Drop foot second, different types of arthritis, balance, and then Charcot. Once again, I send the Charcot out just because I don't, I guess I could do them, but it's just the refitting and adding padding and things like that. I just don't feel comfortable doing that. I don't normally use it for Achilles tendonitis unless there's a really bad, like previous tear. I'm not doing it for every Achilles tendonitis. I'm doing it for some ankle pain, ankle instability. And a lot of times with ankle instability, these people are using it for those activities that make them unstable. For sinus tarsi, lateral foot or peroneal issues, that maybe someone that has failed some of the other types of treatments and they're weak, and then some wounds I'll do it for. So let's get into it. I'm not going to go and teach you guys this stuff, but there's different classification systems depending on the severity of the flat foot. Usually stage 1 and 2, I'm doing an orthotic for them. And then stage 2 and 3, I'm going to be doing either an articulated AFO, which means it has this little something to help it bend at the ankle, or a gauntlet, which is one that doesn't bend. I tend to do something like this. This is a cool brace. We use, I think it's called Insightful Products. This is the one that we use it from. Once again, these are just the ones that we use. And the reason I like this one is because you can see where the navicular here collapses or goes inward, and the malleoli. it has this window right here, so it doesn't rub and cause pain. I find some of the other ones that are solid plastic, they rub. And here's, this is for the malleoli. This is for the navicular, for that navicular drop. Okay. This is another one. Sometimes this can aggravate it. So people pronate, they'll pronate over this thing, and this can sometimes bother people. Okay. So that is, that's another type that you can use. This is a more common one that you can see. It has a orthotic inside. Stage 4, if they have really bad arthritis, I totally stop the movement of the midfoot and the ankle. And this is one that you can use for this as well. Hard time finding shoes for these, for patients. So this is the posterior tibial tendon dysfunction checklist. This is what I use for patients when I'm showing them and I'm explaining this to them. So once again, I have something called patient presentations, you can see, but these are all the presentations that I use. These are the checklists that I'll use, that I'll try these things first. Usually get an x-ray, maybe an ultrasound, an MRI. If I'm considering surgery, mostly for an MRI, I'll try shockwave first, maybe a cortisone, physical therapy, things like this. And then I'll have this AFO. So as the patients come back, I'll pull up this list and I'll say, okay, what have we tried? And now a lot of times with this list, they'll actually ask me, hey, doc, I haven't been in a walking boot yet, or I haven't done an orthotic, or I haven't done just a regular ankle brace. And they'll ask me for these, but I also have AFOs in this checklist. So I'm gonna pause here, and I just want to show you. I talked a little bit about ultrasounds. This is another slide deck I have with ultrasounds. And when I do an ultrasound, I'll actually pull this up when I'm talking to a patient on about ultrasounds. And like we talked about posterior tibial tendon dysfunction, I have ultrasound examples for all these. So when they come in for ultrasounds, before I actually do the ultrasound, I'll show them the ultrasound examples, what I'm thinking I'm going to see around the tendon, and some of the anatomy, so they can see where I'm looking. And then after I do the ultrasound, I'll take pictures, show them. I usually have them take pictures with their cell phone. That's just a good tip. And then I'll have my checklist right here. Okay, this is an older version of it, but I'm always kind of modifying and updating these. So this is how I used the ultrasound slide deck. There is also, this is the posterior tibial tendon and flat foot slide deck that I use. Like I said before, I actually have this stuff included in here. I'm not going to go through everything. This is the brace. You can see the brace is in here. And then as I talk to them, I have ultrasound examples, and then I also have bracing examples in the actual presentation that I'm showing them. So it's kind of a cool thing, makes it a little bit easier for patients to see things. I like to use visual images, and I just put these in my up on top right in my Google Chrome, so I can pick them. So drop foot's another one that I use it for. Dorsey assist AFO, solid ankle AFO. This one doesn't move, and then a leaf spring. So I like this one. This is a Dorsey assist. It has these little jelly bean things that you put in there that pop it up as they walk. So it pops it up as they walk. Here is a solid ankle one that I don't do this one that much. If I send them out, this is what they tend to get, but I find that they're just more cumbersome for patients. And you can also use a balance brace. This is an example of a balance brace if they have less of an involved issue. And here is something like a carbon fiber that goes up in the back. So there's different types. Pick one, just pick one that you like and start offering it to patients with drop foot. Okay. Ankle arthritis. Once again, you can do articulated or a gauntlet. Once again, even though they have arthritis, a lot of times I'm still doing an articulated because I think it's easier for them to get used to something that bends in the ankle. Depending on the severity, they can still tolerate that. If it's really, really bad and they're kind of needing a fusion and they don't want to do that, then we'll do this type of a gauntlet for arthritis. There's this cool one, if you haven't tried this, this is called a meso brace. It's basically just a gauntlet type just for the middle foot. So it encapsulates the heel and the midfoot. It has a kind of a biased lacing right here. So if there's any dorsal exostosis, it's not going to push on that. And then they kind of lace it up right there. And we can, that's the gauntlet. And so here's this arthritis one right here as well. This is the arthritis checklist that I use. Similar thing. They all kind of look the same basically because I copy and paste it. And it has the AFO thing right here. A lot of times, once again, they'll ask me about a walking boot. Some people ask me about shockwave. I don't do tons of shockwave on arthritis. I don't think it works great. But for some patients, they maybe have tried cortisone injections, other types of things, and they haven't gotten better. I'll do that. This is one for ankle pain and sprains and instability. They're very similar. So if you look, they're like the similar braces. Basically, they're controlling motion in different planes. So this would be sagittal. This will allow sagittal plane, but it won't allow like inversion and eversion and things like that. So you have to just kind of figure out what type of plane you're trying to correct, and you'll use that brace accordingly. This is my ankle sprain. One, I usually start with a like an ankle brace before I would go to this. So they might try a walking boot and things like that. They might try shockwave. They could try a lot of other things. This is for instability and balance. This is a balance brace. Once again, I don't use these for everyone, but what I tend to look at is if someone comes in with a walker or a cane, they might be a good candidate for this because they probably have some balance problems. And this is an example of a patient of mine that's walking. You can see how he does have this abnormal gait and this drop foot and hip instability, and even just almost falling over as he's going around the corner there. Okay. So this was him before, and he's a little bit better afterwards. You can see. Oh, this is the same one here. Here's the afterwards. So here he is afterwards. He's walking a little bit better. He still has that kind of hip drop. I think he has some hip weakness, but his gait is better, and he loves these things. He loves these balance braces. He's so happy he got them, and he can get a new pair every like 5 years. Charcot. Basically, I'm not going to go all the medical details of it, but in terms of the bracing, I keep them non-weight bearing for 6 months, but who can keep someone non-weight bearing for 6 months? You can't, it's hard. So I usually start with the crow, and then I move them to a patellar tendon bearing brace. This is a example. Once again, I don't do these in the office. You could. I send them out to hanger. They get this thing, and they usually have to add more padding because it tends to piston. Example of a current Charcot foot that I was dealing with. Collapsed. So this patient, this is very recent. He has this ulcer down here. We're treating. He has this knee roller, you can see, and then he also has this. And so he's getting around. He's walking a little bit, but we're waiting. And this takes a good 6 months. I'll see them every month for X-rays. And so I actually make 6 visits, just so you know. Just another thought about practice management. I'll make 6 appointments a month apart, and I'll have X-rays every single time. So I'll follow them that way. Now, if he has an open wound, I'm probably seeing him every week or two, probably every 2 weeks, unless it's infected. From the crow boot, once things solidify, then I'll put him into this patellar tendon bearing brace. This is once again done by the other clinic. And this is something that I do. And then after, if he's stable enough, then I'll try to put him either into a brace like this, like an Arizona brace or something similar. This is another patient. This is kind of an interesting patient who had Charcot, but he also had something right here in his foot where his bone was disappearing. And I got an MRI, and then I did a bone biopsy. And here's the bone biopsy where I did it. And he actually came up with lymphoma of his foot, and he had to have radiation. And then all of his bones kind of appeared again. It was interesting. So except that defect, right where I did that biopsy. But he ended up having a lymphoma that he was treated for, and then he ended up getting Charcot. So this was kind of a challenging one. I've had one patient with bilateral Charcot, which is kind of a pain because he was in 2 crow boots at the same time. That looked like Herman Munster. So here are some shoes. And afterwards, if I can, I can put them into a shoe, probably not a low top, probably a high top type of a shoe. Once again, I don't do these. I send these out as well. So here's for Charcot, where I talk about different phases. Some of my patients, I have them go to Amazon and get like a temperature tracker. I think patients like to do something so they can track the temperature if it's getting cooler. Then I'll do bracing and things like that. For Achilles pain, occasionally, if it's chronic and it's not getting better, I'll put them in some type of a brace. Now, I know this is articulated, but once again, I think articulation just helps people to get used to wearing it a little bit more. You could also do a gauntlet type. Here's my Achilles tendonitis one that I do. I might use a heel lift. They might use a walking boot initially. Most of them get shockwave. Everyone will get shockwave. Occasionally, they'll get amnio if there's a lot of degeneration and they're willing to do the amnio. But the amnio is a lot more expensive. I learned this from someone else. This isn't mine. The way I explain shockwave is I say it's kind of like core aeration for your lawn. If you have a bad portion of lawn, it makes little holes in it and lets your own, like the water and all the good stuff go into it. And then amnio is kind of like throwing fertilizer on it. So it comes from outside and you put fertilizer on it. Those are good kind of analogies, how to explain that. For the lateral ankle instability, There are some things for the outside. Once again, you can use this articulated AFO, a gauntlet AFO, but this is kind of a cool one where it similar to the medial one that allowed for protection medially from the medial malleoli. This one protects laterally and helps them not to roll out laterally. So this is for a patient that you can use as well. This is for my cavus foot or my a lot of these patients, I'll do custom orthotics first. So a really, really high contouring orthotic for them. And they might do like a brace. The brace that I like to use, a non-custom one, is a Velocity. But once again, to be careful with same or similar, and that's kind of beyond this, that would be in that 30-day practice blueprint. You can find more stuff on the same and similar in the different verbiage that we use. So that's what I wanted to cover today. I want to share with you guys one other cool thing before we finish up. And once again, if you have any questions, you can email me, Donna, at Podiatry Practice Mastery. And since this is a master class on this, I always like to share kind of the newest things that I'm working on. So the newest thing that I'm working on right now is this welcome presentation. Now, let me explain the backstory behind this. There's this guy named Paddy Lund. He is a dentist in Australia. And he had a presentation where when he met patients, he kind of explained his philosophy, what he expected from them, what they expected from him. And then he actually asked for online reviews and referrals right at the first visit. And I had a hard time remembering everything that he talked about. So I find it just easier. That's why a lot of times I use these presentations. I can just explain it to patients. So this is a special bonus for you guys. About this. Let me share this. Now, this is I've only been doing this for a couple of weeks, and I'll explain what I've learned already. So what I do is I see a patient, I start seeing them, and I listen to them. Say, hey, what's your problem? Once they show me and talk to me, I'll document it. When I'm finished documenting, because I'm already in the chart, then I'll pull up this presentation. I'll say, hey, I like to go over this first time patients come in just to introduce them to the practice. So first of all, welcome to the practice. I want to tell you a little bit about me. I think it's good to build this rapport so they can see my daughter. They can see my son here. And I say, she is 7. He just turned 6. This is my wife. She's from Brazil. We're at the Manaim. And I just kind of explain things about my family because patients like to get to know their doctors. And I explain these are the other 4 doctors here. I talk about my partner, Neil. Usually make a little joke, a couple of other doctors that are starting out. So I'll share this with them so they get to know the office. I'll talk about my educational content. So if you guys want this stuff, this is on drpelto.com. And I'm usually sending this stuff out to my patients. And I say, and today I'm going to send you my welcome packet. Okay. This is everything you need to know about getting your foot pain passed. Now, this can be found on my Dr. Pelto if you want to see it, but I'll preface that I'm going to be sending out this content. I talk about that we're board certified. Patients like to know that, part of ACFAS, where we do surgery at different hospitals. And then I'll tell them, this is the key, okay? I say, this is my commitment to you. You're going to have total satisfaction. You're going to get excellent care. And I want to treat you as family. And I really kind of emphasize that. We're a smaller practice. We're not hugely overbooked or anything like that. So we can treat people nice. And I'm going to give you timely communication both to you and your portal, and also to your primary care and other specialists. Now, I just emphasize to them, this is kind of what I say, I can give great referrals to experts. And I think that is key. That's what makes us look good, having a good referral team. And so that might be to one of my other doctors that does more of the reconstruction surgery, Dr. Saviat, or it might be to a great physical therapist, it might be to a great massage therapist, might be to a nutritionist, might be an endocrinologist. And so I think, and I really emphasize, this is the value, this is what I'm going to give them. Okay. But then this is the cool part. I say, but your commitment to me is this. Now, this is the cool part. Okay. If you make your appointment, you're going to keep it. So I emphasize this. I actually use my finger as I'm talking about this on the screen. I want it more than a doctor-patient relationship. I want a friendship with them because I truly do. If you have any dissatisfaction, you respect me enough to tell me. And I say that outright. Like a lot of times people get frustrated and they may have come from someone else and they get frustrated. And I want to know that. If you're dissatisfied, you don't have to stay with me. And I tell them that. But then I say, but if you are satisfied with your care, this is the key. You're going to take care of your payments because I don't like to deal with money. So my staff deals with it. I don't want to have that conversation. And then you're going to refer 2 other people of comparable quality to yourself. So I say this the first visit, 2 other people with comparable quality. This wasn't my idea. This was Paddy Lund's idea. And then you're also going to give me an online review. That's how we get so many of our patients. Does that sound okay? Or how does that sound? And they always say yes. And then I get into things. This is the first visit questions that I go over. I might even be going over some of those prior to seeing them. I say, how did you hear about us? Have you seen another podiatrist for this issue or provider? Could be an orthopedist, could be primary care. Anything you're not happy about, so I can know what they don't like. Anything you're happy about. And then what are the two main things you'd like to accomplish? So I want to know what's going to make them satisfied, what's going to make them wowed with their visit. And then I also, in terms of urgency, why is this important to get rid of the problem as soon as possible? Like what brought them in now? What they have a race they're trying to do. They have a wedding they're trying to get to. Kind of what's the issue? So these are the first questions I go over. And then what I have here, now I'm going to get rid of my head here. I don't really like my head here. But what you're going to see here are the diagnosis. And what these do is these link to my presentation. So I'm kind of having a whole spectrum now. So if they come in for plantar fasciitis, I put the things I see most commonly up front here. So if they come in for plantar fasciitis, it's going to automatically open up my slides for plantar fasciitis, and I can go right into that. So it's kind of cool. And a lot of times I don't go through the whole slides. I'll send them a video or something else afterwards with it. So that is what I wanted to share with you, guys. And as a kind of an added bonus, this is something I'm working on. I'm probably going to add that to the 30-day practice blueprint. But if you want to see it, if you go to the welcome package within drpelto.com, I'll add the video kind of explaining how to do that. So you can try to do it by memory, but I just find that the slides work so much easier, and all of us have, we have computers in the treatment rooms. So once again, thank you for watching this masterclass. This is I think the second one that we've done. And please share it with friends, share the link if you liked it, if it was beneficial. Put your comments underneath it, and I'll try to get to you and answer them. And once again, if you have anything, email me, Don@podiatrypracticemastery.com. Thanks.